Thank you so much. First of all, I want to thank all the organization for this kind invitation. I'm really pleased to be here. It's first time for me in Lebanon, and I'm really surprised that I hope I can stay longer in another occasion. So this is the first talk. It's a little bit technical, but I think that for interventional cardiologists it will be fine. We just give a technical overview of all the steps for a safe and effective mitral clip procedure, and then we will review some typical echo anatomies where we can implant mitral clip and some more advanced cases with some recommendations for patients. So first slides is just to introduce the device, because sometimes we do not think that this has several components, and we must know how to work with all of them. Mitral clip has three catheters that are assembled in like a telescopic manner. First catheter is the guide catheter that is introduced in the left atrium. It has a deflectable tip that you can move, bend it more or bend it less. You have an hemostatic valve, and you have as well a dilator with echogenic markers that allow us to know that when the guide catheter is approaching the left atrium. This guide catheter, it's important for us because not only hosts the real mitral clip device, but also allow us to move and steer the clip in the left atrium, mainly in the anterior and posterior direction. Then we have two catheters that are coming together. That is a catheter delivery system. Then we have a steerable sleeve that has this, I don't know, I have some here, has, no, I don't have the point. Okay, we have these knobs here that you can observe here. This is the knobs of the steerable sleeve that allow us, as you can see in the bottom, to deflect the steerable sleeve in the medial lateral direction and in the anterior posterior direction. And then we have the control, the handle, where you can control the clip. This is the third catheter. And in this handle, we have several components. We have the lock lever that when you actionate this, you allow to unlock the clip and you can open it. Then you have the arm positioner knob that allow us to open and close the clip. We have the gripper lever that allow us to move up and down these metallic paddles that are used to capture the mitral leaflets between the clip and these metallic components. And then you have this, when you lose this screw here, you can move to and fro this handle that allow you to, sorry, I wanted to hit here. Oh. I don't know if I can move this. Okay, I can't. You can move it to and fro, and you can advance and put back your clip just to make it closer to the mitral valve or remove it from the mitral valve. When you see all the components together, this is how it looks like. It's a little bit complex, but at the end it's quite easy. You see the guide catheter. You see the clip entering the guide catheter with the controls of the steerable sleeve and the clip delivery handle, and all these catheters are put on this metallic frame that is the stabilizer. That is quite important because it will allow us to move as well the clip in a medial lateral position. As you can see in the bottom, the movements that we can achieve with these catheters are summarized there. The guide catheter, you have to remind, is the important part when you want to go anterior or posterior with the clip. The steerable sleeve with these knobs is mainly this knob, the M knob, is the one that allows you to come down to the mitral valve. The clip delivery handle allows us to unlock the clip, open the arms, grasp the leaflets, and close the clip. And the stabilizer allows us to move medial or lateral if you push it into the LA or you retract it. So to do a safe mitral clip procedure, you have to follow some basic rules, that if you follow these basic rules, it's easy and reproducible to do the mitral clip. So we have to know that every turn in the knobs I show you will induce an extra displacement of the device. That must be corrected. We'll see it in a while. If you turn the M knob, the mitral clip will go not only in a medial direction, but always in an anterior direction. So you have to correct this. It's important. Every time we make a turn in the knobs, it increases as well the tension in the device. So you can have, if you move and you want to go with your clip to the yet you want to treat, maybe the clip won't go to that direction if you turn on off previously. So you have to release that tension. That this is important. We must ensure that our trajectories with the clips are straight, with no deviations, because this is one important thing that makes the result reproducible. The grasping, that is when the clip captures the leaflet, must be perpendicular to the coaptation and should be symmetric. What I mean for symmetric is there should be ideally the same part of the posterior and the anterior leaflet inside the clip. If this is unbalanced, probably the result we achieve with the clip it's not perfect. And we should combine transesophageal echo and fluoro to optimize these steps. First step in mitral clip is the access to the fossa, as you can observe here. This is in the top part here. We have our catheter that is here, and this is the commissure. This is the aorta, and we have here the posterior leaflet, and then the anterior leaflet and the commissure. We have two objectives in the transeptal puncture in mitral clip. First objective is to gain some height to the mitral valve, ideally above 4.5 centimeters. With the new version of the mitral clip that we are using now in Europe, the NT, we have to be closer to 5 centimeters. This is important because it allows us to move some trajectories before entering in the LV to release the tension. It is important. And the puncture should be centered regarding the commissure, because this allows us not to make asymmetric graspings. To do so, we have these 3 axes, you see. One is the bicaval view, that is in the top left, that allows us to move in the superior-inferior direction. Then we go, when we reach with our transeptal catheter, we go to the short axis that we see if we are anterior or posterior, but the most important one is the 4-chamber view, because this gives you the real height over the mitral valve. So ideally, you have to be posterior, that means that you are centered over the commissure, and 4.5 centimeters in the 4-chamber view. This is the ideal transeptal puncture. Of course, transeptal puncture might be modified depending on the etiology of the mitral valve disease. If you have functional MR, usually the coaptation is down in the ventricle, so your puncture should be a little bit lower. If you have degenerative MR, your valve will be up in the LA, so you need a higher puncture, so you have to modify this. Once we have the transeptal, we have to introduce the guide catheter in the LA. Important to see the echogenic markers arriving to the LA, but it's important to see as well that our catheter goes through the septum, because sometimes we are pushing, we think we are in, but we are not in until we see, like in the video, the catheter entering finally to the LA. This is important that the echo guys confirm this. Sometimes we have tough septums, and to gain the enough height to do the mitral clip, we have to puncture outside the fossa. This is the last case I did. One of the last cases I did, you looked at the lipomatous septum, and if you see in the left, the real 4.5 centimeters were out of the fossa that is here. Sorry, it's here. And I have to move here to make the puncture. So sometimes you need some tools to do a transeptal out of the fossa, like balloon dilation, or dilate these septums with the Inoue balloon dilator. Or sometimes you have to use special wires to cross the septum in not a fossa place, or use the diathermia or the Baylis, that is a radiofrequency transeptal needle, to enter in the right spot to do the transeptal, because transeptal is, a good transeptal is 70% of the procedure, and you have to keep this in mind. Once we enter in the LA, and this is a reconstruction over a CT scan, the direction of the clip is this. You enter to the left superior pulmonary vein, and then you have to come down. You have to enter the clip in the LA until you reach this straddling. That is where the 2 radiopaque markers of the clip straddles over the radiopaque marker of the guide catheter. This is how it looks like the catheter inside the LA. It's moving to the lateral part, and then it's easy to understand that when you release the clip, when you put the clip in the LA, you have to go medial because you are going lateral. And this is how we reach the straddling. You see in the right panel how the 2 markers of the clip straddle over the marker of the guide catheter. This is the straddling position. That is the position when the clip has less tension and is easy to bend. Okay. Once we enter in the LA and we reach the straddling, we have to do the medial deflection. And it's important to do no much M. Don't be very fast with the M knob, because otherwise it will get some memory, the clip, and it will go all the time M. So you have to do it very gently. Go M to reach the valve, and as I told you before, when you move the M knob, the clip will displace anteriorly. So you have to correct it, and we correct this with the guide catheter. So every time we turn the M knob, we see in the echo view we are going anterior, we correct with the guide catheter a little bit posterior to be centered over the valve. Every time we do the M knob deflection, the steerable sleeve will appear, this one. So we have to, you see this part is coming out of the steerable sleeve, the clip is coming out this space. So we have to loosen the screw, the black screw, and retract a little bit the CDS handle in order to gain this distance. And when it's enough M deflection, which as a rule of thumb is a non-deflection when you reach almost 90 degrees between the catheter and the clip. And you can see it in the echo as well. When you reach this, what you have to ensure is that you have straight trajectories with notation. Your clip should go where you want to go. It shouldn't turn medial, shouldn't go lateral, shouldn't go posterior, should go straight to the point. And you can see in this easy drawing, this is the good way of doing it. Your clip straight to the central part of the valve, the jet is here, and this is wrong, because you see now, if you get this, that is one of the main mistakes. You know what you see. This is a clipping with the clip entering a little bit to the medial part, what we call diving. If you do a grasp with the clip entering a little bit diving, you see in the right panel the result. You reduce the MR, but the reduction of the MR is not correct. And you have these eccentric jets that usually is produced by mitral valve distortion, and the results in the long term are not correct. When you correct the trajectory and you do a straight trajectory, you see the difference with the reduction in the MR. You have a huge reduction in the MR, and you don't have the eccentric jets, so your valve is not distorted. This is important. The difference, the bad grasping, bad trajectory, and good trajectory in the right. Keep this in mind, because if you do it not symmetrically, if the trajectory is not correct, your result won't be correct. Once we reach the straight trajectories to the point we want to go with the clip, then our movements in the medial lateral will be done, as I told you before, with the stabilizer. And our movements in the anterior posterior plane will do it with the guide catheter. The optimal clip positioning is in that place that breaks the jet of the mitral regurgitation in two. This is a rule of thumb. You split the jet. This is the why we do it. And we do it like this because this is a technique that tries to split the jet in multiple jets. It's very difficult to reach 0 MR, but you need to reduce the MR enough to leave not significant jets. So go to split the jet, and depending on the result, you can use one or more clips. When you are over the jet, you are in the correct position. The next critical point is to be perpendicular to the coaptation. So to be perpendicular to the coaptation, we need several images to get this information. This triple imaging, that is what we use usually. We have the 3D and fast view, when we have to see the clip that is perpendicular to the line of coaptation. In the bicommissural view, we don't want to see the arms of the clip, we just have to see the bar. And in the LVOT view, we must see fully open the arms of the clip. With these three images, we are sure that our clip is perpendicular. If we are not perpendicular, we have to correct this perpendicularity by turning the CDS handle until we reach the perpendicularity. And every time we turn the handle, we have to move a little bit to and fro the handle to release the tension. We can put as well our fluoro to see the clip like in the right panel. When we see the clip like this, the clip, we won't see the arms, the clip is perpendicular. So this is also an extra information you have apart from the echo to see that your clip is perpendicular, because when you do the grasping, sometimes when you enter in the ventricle, the clip turns and you can come back again, returning the CDS handle to the previous position with the fluoro to ensure that you are perpendicular. Once you enter in the ventricle, first clip enters usually with the arms open. Be aware of the cord. If you entrap in the cord, this is a problem. And when you want to do the grasping, there's two ways of doing it. The good way is like easily retracting very gently the clip and watching with the echo that both leaflets are inside the clip, then dropping the grippers and slowly closing the clip. This is the best way of doing it, but sometimes in difficult cases we can do like in the right panel, that is very fast to capture the leaflets, and do it like very fast. It's not the best way, but sometimes you have to do it like this. And always making sure that your clip is completely perpendicular when you check it with the fluoro. If you don't want to, your grasping, you feel that is not correct, or your entrance in the ventricle is not correct, you can move a little bit inside the ventricle, but what is most recommendable is just to invert the clip and retract it into the LA and start again the procedure. This is one of the main advantages of mitral clip, safety. It's very safe, and we can do it very safe. And if we do it very safe, it's the way of having good results. If we have an extra jet, as I told you before, after implanting a very good clip, then we go with the second clip. The better way of doing it is implanting the second clip lateral to the first one. It's easier for the echo, it's easier for us not to move on top of the first clip if we go medial. Better go lateral. You can check the perpendicularity by fluoro. It's more fluoro guided, the second clip, than the first clip. You have to enter in the LV close in order not to get attached to the other clip, and never go below the first clip, because this is, if you go below the first clip, there's a high chance of getting trapped into the corda or with the previous clip. And try to get the optimal result. When entering in the LV, it depends as well on the in the LV axis. As a rule of thumb, our clips should always have to point to the apex. So it depends in the axis of your heart. Same trajectory is not the same for the same heart. So it's important, as I told you before, that we have to enter in a symmetric position. Look at this right panel, the clip is entering to the posterior wall, not to the apex. We have to correct this, otherwise our grasping is not correct. And how we can correct this? Then if our clip is entered into the posterior wall, then the way of correcting it is using the plus of the guide catheter. That will allow us to enter in a more symmetric position. And if our clip is entering, because we did a very posterior puncture in a kind of anti-aortic hugger position, we have to use the minus of the guide catheter, straighten the guide catheter and correct it to the posterior to get to the apex. This is the way of doing it. Regarding anatomical issues, this is a well-known table where German colleagues explain how can we select patients based on the anatomic of the mitral valve. So we have the optimal characteristics for mitral valve clipping. That it's quite common sense, because mitral clip is a leaflet procedure. So what you need is a good leaflet quality and not very complex disease. This is the optimal anatomical morphology. And this is as well the Everest criteria. Everest criteria were thought to be used by one single clip to reduce the MAR. But we have as well, with increasing experience, possible anatomical scenarios that are a little bit more difficult, but with experience you can have as well very good results in this one. And of course you have the difficult one that probably you have to avoid. This is Everest criteria, as I showed you before in the table, regarding DMR and FMR. If you see it moving, this is a prolapse, not very much prolapse, not very wide, very good case for mitral clip. And this is functional MR, central, not very depth coaptation, with good coaptation with the leaflets. In the functional mitral regurgitation, if they attach to the Everest criteria, usually we can implant a clip in the center of the valve and obtain a very good result, as you see in the bottom panels. This is a patient, was my first patient treated, that was in 2014, and 3 years after clip, he is still with no significant MR, he improved LV function, no pulmonary hypertension, and is in NYHA functional class 1. So, although you have very high-risk patients, the patient may behave properly. So in the functional mitral regurgitation strategy, as a rule of thumb, first we have to try a central clip, because this induces the less mitral valve distortion. Sometimes in ischemic MR you can try the central clip, but sometimes you have to start in a medial, because in the medial part of the valve, because in ischemic MR there's a deformation of the valve to the medial part, usually because it's produced by inferior lateral MI, previous MI. So you have more component in the medial, so you have to sometimes to start medial. You have to achieve the less MR possible, but in these functional patients with severe LV dysfunction, you have to balance a little bit the MR reduction with the hemodynamics. So if you have a nice MR reduction, but still some MR, but your V wave decreases, your cardiac output increases, and you think it's enough for your patient, the heart failure patient, then it's enough. And as I said before, you have to split the jet. For patients with DMR, as you can observe in this slide, this is a typical flail patient or prolapse patient. We treated with a couple of clips more than 1 year ago. This is the final result, and this is the evolution 1 year after the clip. He's mild MR, normal LV function, no pulmonary hypertension, and in a good functional class. So the strategy in DMR, the first clip should be directed to the center of the prolapse. This is the rule to maximize MR reduction, and we need extra clips into situations. First situation that you have a lot of residual MR, of course you need a second clip. But if you have no much residual MR, but you have a lot of extra movement of the segment which you treated, you have to implant a second clip. So you have to be guided by these two principles. And usually, although it's a small prolapse, you need 2 clips to make sure that your reduction is stable during time. But as I told you before, once you gain experience, you can treat more complex patients. This is a FMR patient with no Everest criteria. The no Everest criteria, as you see, is the very deep coaptation, more than 11 millimeters. And if you see here, we don't have, the leaflets are not touching. Most of centers in the world, this could be dismissed as a case for MitraClip because it does not fulfill the criteria. But we treated because we have some experience, we implanted 3 clips, and you see how it was the result, quite all right. And the most important thing, as I told you before, you have to check the hemodynamics, balance the MR reduction in functional mitral regurgitation patients with the hemodynamics. This is before MitraClip, you know, huge V wave, almost similar, the peak to the aortic pressure with low cardiac output state. And after clipping, you see almost normal pulmonary wedge pressure with improvement in the cardiac output. Regarding DMR, Everest criteria told us that you have to treat only central pathology, but with increasing experience, we have treated as well non-central pathology. We've published this some time ago. The double orifice that is obtained usually with MitraClip is changed to a single orifice bigger, but we have seen that this is equivalent to the central part when you have experience in the reduction of MR and the improvement in the functional class. So this is an example. I don't know if I can. Well, this is an example that I cannot move, but we are treating the lateral commissure with 2 clips. I can go back a little bit. The lateral commissure with 2 clips. You see it? This is only one orifice, but we can do it with experience. Another interesting anatomical point is the patients that develop acute mitral regurgitation after myocardial infarction. These patients, sometimes there's a spectrum of these patients, but these patients sometimes has what we call the partial papillary muscle rupture, that is a mix of posterior restriction and pseudoprolapse of the anterior leaflet with a huge gap. These patients usually tolerate very badly the MR, they are in permanent heart failure. They are high-risk surgical candidates. Sometimes they have been previously treated with a stent during the acute phase, so they are in dual antiplatelet therapy. And with the ongoing myocardial infarction, then surgeons usually don't like this type of patients. They try to cool them down, but we have proved that we can treat this with MitraClip, with a couple of MitraClips with good result. And this is the final result with after 2 clips. A very high-risk patient dismissed and turned down for surgery with no other options that we treated, and the patient is doing really fine right now with an hemodynamic improvement. You see the pulmonary vein flow. So we collect a little bit these cases in a publication we did in the JAC a couple of years ago, and in Spain with 5 cases treated in our experience, we have seen that for these high-risk patients that might be an option, and you have to bear this in mind. Another place that we can implant clips is in failing surgical rings. This is, of course, you need experience to treat these patients, but if you have good imaging, you have a good posterior leaflet, then you can treat it. Usually single clip is enough, and you usually have a very good results and no problems of mitral stenosis. That is one of the concerns in these cases. Another anatomical scenarios that we can treat as well, but with huge experience, are complete papillary and muscle rupture that has been published, and as well severe MR produced by systolic anterior movement in hypertrophic cardiomyopathy that are not amenable for surgery, of course. So you have to bear this in mind. I want to leave this here because when I was talking yesterday with all of you colleagues, you told me that you have some difficulties to find these patients for treating with MitraClip. So as you have all my presentations, I want to leave this. This is the summary of a consensus of the South Europe interventional cardiology societies. So you have to have this in mind to plan your patients for MitraClip. Surgeons don't have to be scared of this because all of them are poor surgical candidates. So this is not a fight, this is a complement. But I want to leave you this table and this slide just to keep this in mind, to send you to your colleagues. Please, if you have a patient like this and is symptomatic, comment in the heart team, because maybe he can be benefited by the MitraClip therapy. So let me conclude that MitraClip procedure is easy and reproducible, following some recommendations. Evidence criteria should be a starting point for a program, but increasing learning curve allow to treat more complex scenarios, as I show you, with good results. And please keep in mind this table, because it's the starting point for collecting more patients for MitraClip. Thank you so much.